the Southern Legislative Conference webinar on the growing heroin epidemic in the SLC states and what those states can and are doing to address the crisis. My name is Lauren Greer, and I am the Human Services and Public Safety Analyst with the Southern Legislative Conference in the Southern Office of the Council of State Governments. Thank you for taking the time to join us today. And before we begin, let me note that you are in listen-only mode. However, if you would like to ask a question during the webinar, please type your query into the GoToWebinar question box located on the toolbar at any time. We will try to get to as many of your questions as possible before the end of our program. Finally, please also note that this broadcast is being recorded, and a copy of the webinar and presentations will be available on the CSG website at knowledgecenter.csg.org and on the SLC website at slcatlanta.org. At a time when many states in the southern region and across the country have begun to make strides in combating rampant abuse of prescription painkillers, recent reports from the Centers for Disease Control and Prevention reveal a significant increase in the use of heroin in the United States between 2002 and 2013. With increases spanning across gender, age gaps, and all income levels, the rate of death from heroin overdose has nearly quadrupled during this time. In 2013 alone, more than 8,200 people died from a heroin overdose. As opiate abuse and addiction continues to rise to the levels of a public health emergency, states have begun to grapple with what resources and protocols are necessary to intervene with those already addicted to the drug and mitigate its side effects. They also are trying to determine what measures can be implemented to prevent others from beginning to use heroin and other opioids. Today, we're honored to have three experts who will provide us with some insight on this crisis and what policymakers can do to address the problem in their states. Once we've heard from each of the presenters, we will then take questions from the audience. Our first presenter is Mr. Jack Killeran. Since 2006, he has served as director of the Atlanta, Carolinas High-Intensity Drug Trafficking Area. Prior to being named director, he gathered more than 30 years of experience in local and federal law enforcement and private security, including positions with the Bureau of Alcohol, Tobacco, Firearms, and Explosives, from which he retired in 2002. He's a graduate of St. John's University in New York, and he served in the U.S. Navy. Our second presenter is Mr. Robert Childs. Since 2009, he has served as executive director of the North Carolina Harm Reduction Coalition, where he oversees the agency's operations and innovations. He specializes in HIV and hepatitis prevention, harm reduction, drug policy reform, drug overdose response, and community-based overdose prevention. Among his proudest advocacy achievements are successfully leading efforts in North Carolina that resulted in the first Republican comprehensive overdose prevention bill and partial syringe decriminalization. Since 2013, he's gone on to provide technical assistance on similar legislation in Georgia and South Carolina and has continued to work on enhancing harm reduction laws in his home state. Our final presenter is Representative John Tilley from Kentucky. Currently in his fifth term in the Kentucky House of Representatives, he has served as House Judiciary Chairman since 2009. He has focused his legislative efforts on implementing evidence-based policies aimed at combating substance abuse, maintaining public safety while reducing recidivism, protecting victims of domestic violence, and assisting active and retired military. In doing so, he has led several successful bipartisan reform efforts, including the Commonwealth's 2011 criminal justice reinvestment legislation that, among other things, expanded substance abuse treatment opportunities for nonviolent drug offenders. I will now turn it over to Mr. Killeran.
Thank you very much, and good afternoon, everybody. We can go to the next slide. The Atlanta, Carolinas HIDA is one of 28 in the United States. These are joint federal, state, and local task forces funded out of the White House, the Office of the President, through the Office of National Drug Control Policy. They also provide intelligence, training, and prevention support in the communities, although the primary function is law enforcement initiatives aimed at regional and national level drug trafficking organizations. We also work very closely with treatment, prevention, public health, legislative officials in a broad-ranging approach to both stem the tide of illicit narcotics trafficking and promote better public health in our communities. Unfortunately, from where I'm speaking today in Atlanta and speaking for Atlanta and the Carolinas, we are the epicenter of Mexican cartel polydrug organizations delivering illicit drugs, including heroin, throughout the eastern United States and into the eastern provinces of Canada. Next slide, please. I think it's very important, if we're going to talk about heroin, that we really need to reference that in a continuum that we can see beginning with pharmaceutical abuse that both trends to and supports abuse of heroin, and we'll need to make some mention of at least an adjunct problem that's arising out of that, which is the addition of the painkiller fentanyl to heroin and to other drugs currently moving illicitly in our communities. However, currently, in terms of pharmaceuticals, we have the 36th highest drug overdose mortality rate in the United States. Most drug-related deaths are due to prescription drugs, or at least prescription drugs in combination with other substances. Those deaths are greater than methamphetamine, cocaine, and heroin by itself combined. And the Fulton County Medical Examiners reported 123 drug-related deaths in 2013. 41 were solely attributed to pharmaceutical drugs, while, as noted, 25 were prescription drugs combined with an illicit drug or alcohol. Next slide, please. What we're seeing is pharmaceutical drug abusers, whether they come into it either through an addiction developed through what was initially a medical prescription, or, as we've seen for the last several years, whether they're coming into it through kind of a social epidemic in which pharmaceutical drugs, opiates in medicine chests are diverted out of the home into the schools. And at one point, the data indicated that pharmaceutical drugs were becoming a gateway drug, if you will, the drugs with which new initiates to abuse and addiction, that the first drug they were using was a pharmaceutical at a rate that was approaching that of marijuana, which heretofore had been solely the primary illicit drug that most people had first contact with. The reason for the switching is, we think it's threefold, primarily threefold. One, if you went to the street to buy a pharmaceutical pill, you would probably pay about $1 a milligram. So for a 60 milligram OxyContin pill, you would pay $60. A single dosage of heroin is approximately half that price. The effects, when you're dealing with opiates, the body adapts to its experience with opiates, requiring you move to a different drug to raise the level of the high or the intensity of the high. Sitting, waiting at the end of the pharmaceutical opiates, the cycle of addiction, is heroin. And now, as I've noted, heroin boosted with the addition of fentanyl, which is a pharmaceutical substance, although being illegally manufactured, that is 50 times more active in the body, 50 times more active than heroin. And finally, the availability of heroin, changes in medical prescription practices, efforts to develop and implement effective prescription drug monitoring programs, educational programs, public health programs, public information. We're beginning to see impact in a downturn of pharmaceutical abuse, but a concomitant rise, which I'll show you in a second, of heroin abuse. Next slide. And you can see that on this slide as you go towards 2013. all of the efforts that have been made that need to continue to be made across the spectrum of public health, law enforcement, primarily law enforcement with regard to illicit pain clinics, public awareness, medical training. We're seeing a downturn in the rate of opioid analgesic death, and we're seeing a rise in heroin. And we think in many ways the opioid abuse is a leading indicator for a rise in the heroin abuse, and we're entering a period as we're gaining traction with pharmaceuticals, we're seeing a rise in heroin abuse. Next slide. I'll go through these fairly quickly. This is heroin overdoses by death. You can see the rate of increase, particularly among men, but followed closely by women. Next slide. By age, and this is signaling a shift that I'll talk about in a second. Next slide. Here's by age, race, and ethnicity. 2010, we'd have told you that heroin overdose death primarily occurred to a non-Caucasian, non-Hispanic male, 55 years of age. Today, I would tell you that heroin overdose deaths are occurring in non-African American, non-Hispanic males and females at an age range in the mid-20s to mid-30s. This is, a lot of us are talking about what we call the newer phase of heroin in the United States. A different demographic, different population demographic, different socioeconomic demographic. The next slide, please. You can see that in some ways those of us in the South have been lagging behind some of the other regions in the country. There's no reason that we should be complacent in the face of that. We're seeing more heroin. We're seeing increasing rates of death in our region. We just seem to be lagging a bit at this time. If there's good news, there's time for us to focus and act on this problem. Next slide, please. I circle this. This is from the Georgia Bureau of Investigation and drug-related deaths. This gives you a sense of the overwhelming range of pharmaceutical deaths in 2013. I call out that circled area where we had 20 heroin deaths and 23 fentanyl deaths. I think you can presume that the fentanyl was mixed with heroin in those fatalities. That seems to be increasingly common in the drugs distributed on the streets in the 3 states where this high-intensity drug trafficking area works. Next slide, please. Heroin availability is at unprecedented levels. The prices remain stable. We'll look at some more data on that in a minute. No question that our traditional role as a cartel distribution center is affecting the amount of heroin available in this area. We're seeing unprecedented multi-kilogram seizures of heroin of very high purity, unprecedented levels throughout. Intelligence from Mexico indicates that the cartels are plowing under their marijuana fields and increasingly planting opium poppy fields to support the demand for heroin that they see in the United States. Next slide. And again, this just gives you a sense of the seizures of heroin that we're seeing. The average seizure has gone from about 0.8 of a kilogram in 2009 to about 1.5 kilograms in 2013. Next slide. And as you can see, the price has remained relatively stable at the wholesale level. Next slide, please. One of the issues that we have is, particularly as we move from state to state, let me describe the situation in Georgia, and people can reflect on how this works in their own location. In Georgia, except for 5 counties, the medical examiners are all attached to the Georgia Bureau of Investigation and their laboratory, which gives us a very high consistency of the level of toxicological screening and the level of examination that's done. Throughout the state, we are a medical examiner state, which means we have a doctor conducting all autopsies. However, in the 5 most populous counties of the state, Fulton, DeKalb, Gwinnett, and Cobb, they are not under the Georgia Bureau of Investigation. They have independent medical examiner programs. This makes it difficult, is one of the levels that makes it difficult to get consistent, timely, and comparable data to be able to measure the problem, to measure the growth of the problem over time, to measure the location where the problem is occurring. And if you begin to look at states that have more diverse medical examination programs or coroner programs, this gets increasingly difficult. Next slide, please. This is one indicator that we've used to try to track the spread of heroin availability in Georgia. These are because the Georgia Bureau of Investigation Crime Lab is the only lab in the state that processes suspected heroin seizures by law enforcement. And this is a pretty typical heat map. This is 2010. These are the counties that were submitting heroin evidence samples to the GBI lab. As you can see, most of it was concentrated in the red area of Fulton County. And if you show me the next slide, please. By 2013, you can see that heroin is becoming more widely available, that it's becoming available, that it's coming into the laboratory in greater quantities of submission or more frequent submissions. And some of the yellow areas have turned red, some of the cooler areas have turned orange, and we're seeing that heroin is much more widely available throughout the state. The next slide, please. And again, just the sheer numbers of submissions. The next slide, please. Here's some data from our treatment friends and partners. Treatment centers, heroin abuse, 30% increase in heroin abuse admissions to treatment centers. Noting again, 69.4% of the admitted individuals were in that age range of 21 to 35. That signals a tremendous demographic shift in the people that are using heroin in the communities. Half were male, 43% were female. We're seeing more female involvement with heroin than historically has been noted. And in terms of race, again, 2010, predominantly African American admissions for abuse or overdoses from abuse. Now we're looking at 81%, 82% if we round up, of the people coming in are Caucasian. Next slide, please. Some conclusions to share, and then hopefully we can move along. The abuse of pharmaceutical drugs and heroin are intertwined, and that is being augmented or made more threatening by the appearance of fentanyl as a boosting additive. We think the primary feeder for the growth of heroin abuse has been the abuse or addiction resulted from, quite frankly, the too readily availability of pharmaceutical opioids, and that people coming into that are seeking a faster, more powerful high. They're used to dealing with pharmaceutical-grade opioids, so they're seeking higher quantities. We're seeing overdose deaths because they're mixing substances. We absolutely, from policy, need to examine our prescription drug monitoring programs. I know that Kentucky has long been a leader in this area with their CASPR system. What we're finding is most of them are voluntary. Where they're not voluntary, it's only for pharmacists. Voluntary systems are enrolling something around 25 to 30% of the doctors that are prescribing. We need to educate our medical community or encourage them to use the PDMP as a diagnostic tool for their patients, their primary care patients. so that they can spot what might be a growing trend toward abuse in that patient and treat them and keep it entirely as a medical and not a criminal justice or public health issue. Clearly, heroin is spreading. I think if you looked at that data in any of the Carolinas, in any of the southern states, and I talked to the HIDTA directors who cover the southern states, and they're all seeing the same thing, wider availability and the same transitions. We also think that the spread of heroin availability is going to be a leading indicator for overdoses. And in terms of overdoses, there are some things we need to also look at. One is the deployment of naloxone. For folks that are not familiar with naloxone, it is in essence an antagonist to opioids. If administered to someone in overdose, it can literally resuscitate them and save their life and give us an opportunity to intervene with them. We have tended to look at that as a public service issue, moving beyond fire and paramedical rescue personnel to being deployed with frontline police officers. When we looked in Fulton County, Georgia, our most populous county, we found that fire and EMS were deploying naloxone to resuscitate opioid overdoses over 1,000 times a year, 3 times a day, spread throughout that county. That has led to the Atlanta Police Department now beginning to deploy it. With the addition of the fentanyl threat, which is 50 times more active, can be absorbed through the skin or the mucous membranes, the fentanyl alarm now spreads to responding police and public safety personnel who may accidentally overdose by having either breathing in or being skin exposed to a substance they may believe is another drug entirely. So that we're now also looking at naloxone deployment as a matter of both community response and officer safety. The Georgia Bureau of Investigation now provides naloxone to every one of its special agents, primarily as an officer safety issue. And of course, if they came across someone, then they could potentially also engage in the rescue. Lack of standard and timely data is truly troublesome to the policymakers. The high-intensity drug trafficking area program in several states have begun very serious conversations about how we can pull in overdose data and begin to do some mapping and understanding of where this threat is occurring. Formulations of the drugs. There is a certain amount of social distribution of pharmaceuticals that is beginning addiction that's moving to heroin. There are formulations of opioid medications that can defeat abuse. Most of these medications are designed to be time release. Most people seeking to abuse it are dissolving it, grinding it, or otherwise trying to interfere with the protections so that they can get that one-time rush. The pharmaceutical companies have developed and are deploying formulations that are not that easy to overcome. It's a very important part of, quite frankly, keeping some abusers alive till we can find ways to reach them. And I think I will end here, and thank you very much for your attention.
Great. Thank you so much for that informative presentation. It really shows the feat that our states are up against. I'll now turn it over to Mr. Robert Childs.
Thank you. Can you hear me okay?
We can.
Excellent. Thank you. Thank you. My name is Robert Childs. I'm the Executive Director of North Carolina Harm Reduction Coalition. I'm also on the State Poisoning Task Force of North Carolina. And you can move to the next slide, please. And today I'm going to talk about some of the things we've done in North Carolina as well as in other surrounding southern states in order to decrease the negative impacts of heroin use in North Carolina and our surrounding states. So I work for an agency called North Carolina Harm Reduction Coalition. We're the only comprehensive harm reduction provider in the state of North Carolina, and we also provide some services to Tennessee, South Carolina, Georgia, and Virginia. pretty much any state that touches our state, we will work with you because our states are very interconnected in our services. Next slide, please. And our agency specifically is very good at lobbying, doing advocacy, implementing harm reduction programs, and building resources that can be replicated in our fellow 7 states. And we specifically really work on reducing overdose mortality, HIV and viral hep C associated with drug use, and also working with law enforcement to incorporate harm reduction initiatives to improve the health and safety of their community. Next slide, please. And our organization, as you can tell, we've been doing a lot of lobbying and advocacy way back since 2009, but we really started to see great legislation coming out of our state that we personally lobbied and advocated for starting in 2013. 2013, we were the first Republican state to run a Good Samaritan naloxone law through the Republicans that passed. And the Good Samaritan law, basically what that is if you are at a drug overdose, it gets rid of criminal penalty for calling 911. So what we were seeing is a lot of people getting arrested for calling 911 at a drug overdose. If somebody's calling 911 at a drug overdose, we don't want them to be afraid to call 911. So what a portion of that bill does is it gets rid of some of the criminal penalties associated with calling 911. So it gives our bill gave immunity to the caller and the victim for small amounts of drugs and for paraphernalia. It also expanded access to the medication naloxone, also known as Narcan, and allowed community members to distribute it through a standing order. It also allowed individuals to use it on anybody in North Carolina if they felt in good faith that there was a drug overdose and they were using the naloxone or Narcan to bring them back to life. It also got rid of all criminal and civil liability for third-party administration and for medical providers who may be writing a script to the person and to third parties. So there was no fear of anybody doing naloxone distribution or getting a naloxone kit and using on anybody. In 2013, we also passed House Bill 850, which was called Have Syringes Tell an Officer, which has since been replicated in Tennessee as well. And what that bill does is if an individual has syringes, they can declare them to an officer prior to a search, and if they declare them, they become decriminalized. The point of that is to decrease HIV and hep C exposures to law enforcement, because what we were seeing is 1 out of 3 members of law enforcement getting stuck in their career, 28% were getting multiple sticks. We wanted to reduce that. We also wanted people to feel less worried about carrying syringes in general, which will lead to a decrease in HIV and viral hepatitis C exposures revolving around injection drug use. In 2014, we had a short session, so we didn't run any bills. And in 2015, we had 3 initiatives passed and 1 that didn't make crossover. We passed a bill that allowed people on probation and parole to call 911 at a drug overdose without fear of being in violation of probation or parole. We also, in that Senate Bill 154, also allowed pharmacies to pass out naloxone through a standing order without having a script. For individuals didn't have to come in with a script for naloxone. They could just give it to them if they noticed that they were at risk. Also, we got $50,000 in the state budget for purchasing naloxone. Half of it is going to our agency, and the other half we lobbied and advocated for law enforcement to have access to that money so they can start naloxone programs. And prior to that money coming in, our agency has helped start 32 naloxone programs in North Carolina and also helped several in Georgia, and has also provided technical assistance all around the country on law enforcement naloxone programs. We also passed House Bill 712, and all our bills in 2015 passed with a unanimous vote. We haven't had a no vote this year. And what House Bill 712 does is it decriminalizes residue in syringes if you declare them to an officer prior to a search, and it also sets up state biohazard collection programs, which is the first time it's being done in the United States South, whereby allowing organizations such as community-based organization and law enforcement to set up biohazard collection programs where individuals bring in biohazards such as syringes and paraphernalia to one of these biohazard collection programs, which could be our agency, a community-based organization, a church, or the law enforcement station or a fire department. They won't be criminalized for doing that. Very similar to a pill take-back. It's a syringe take-back program, and we're offering people naloxone, health referrals, risk reduction education, and drug treatment referrals when they come in to dispose of the biohazard. And another harm reduction bill that didn't make crossover was a ban the box bill. What we find is a lot of people, when they're trying to straighten out their lives after having a history of using, and if they got a criminal record from using, oftentimes, which will lead them back to using, is they can't get employment. So what we did is we introduced a bill which barred employers, unless they were law enforcement organizations or organizations that work with children, from asking an individual about their criminal history until the first interview. So you can't discriminate against people with criminal histories. And what we find is if you do that, which several cities in North Carolina have already done so, is people hire more people with criminal histories and enable them to get employment, which prevents them from going into red light trades in the future. Next slide, please. So that's all that's happened. Besides that, we also do organizing of active users and sex workers, as well as law enforcement and veterans. Next slide, please. And we help them all with reducing their risks associated with drug use, or with the law enforcement with reducing their risks around working with injection drug users, and also empowering law enforcement to carry naloxone, and also look at law enforcement assisted diversion programs in order to decrease community drug use, and in order to give more people second chances in getting into drug treatment, getting into social services, and such. Next slide, please. Our organization has done a massive amount of media work to get people in the know about harm reduction, overdose prevention, syringe exchange, and syringe decriminalization initiatives, and our organization's being able to get over 284 articles published a year, or major media mentions, where we've had features in the Wall Street Journal, BBC. We did a feature with CNN's Sanjay Gupta, which was one of the first major naloxone overdose prevention videos, where we had some people film an overdose reversal to talk about, how easy it is to do, and that also, all people should have access to the great medicine naloxone so they can reverse drug overdoses themselves, especially in rural areas and places with slower EMS response, because even if somebody calls 911, we don't want people having to wait over 20 minutes for emergency response when they can just reverse it themselves, saving hospitals up to 17 grand per drug overdose that they have to treat. We can treat it in the field for relatively few dollars. Next slide, please. So again, we pass out the medication naloxone. The previous speaker talked about it. It's a non-addictive prescription medication that reverses opiate and opioid-based drug overdoses. So it will reverse a drug overdose that is even a speedball, which may be like heroin and cocaine. It will neutralize the effects of the opiate, and it will bring the person back to life. We know if you flood a community with naloxone, that you'll see a 50% drop in mortality, which is utterly phenomenal, and something that all communities should get behind that have been impacted by drug overdose. And you can administer it via intramuscular shot, which is very cheap to do, or a nasal spray, and there's some new nasal tech coming out, making it even easier, and hopefully will hopefully neutralize some of the price increases because there'll be more competition, and it cannot be abused in any way. Medication has less side effects than a lot of over-the-counter meds. Like, you could drink a gallon of it and nothing will happen if you don't use opiates or opioids, but if you do, it's going to neutralize the effects of those. And our organization has used it very successfully. Next slide, please. So before I talk about that, I just wanted to show some folks a good map that is currently out about heroin counties with high death rates of heroin, and you can see in the South, we have several hard-hit communities, especially in North Carolina, Louisiana, and Texas, and Florida, and that have been really hard hit by heroin. But then when we look at the prescription drugs, which is on the next slide, please, what you will see is that our communities are being massively impacted, especially in East Tennessee, Kentucky, Western Virginia, Northern Georgia, and also in Oklahoma, Texas, Florida, and Carolinas. You'll see, especially in the HIDA area that the previous gentleman was talking about, we're seeing a massive amount of overdose deaths. We're seeing more of a shift from that group over to heroin in the last couple of years due to all the factors he identified. Next slide, please. So I just wanted to highlight some of the success of our program. So we started an overdose prevention program back in August 2013. And initially, what we were seeing is we were getting a couple reversals in 2013. We had 35 for the year. And then we started expanding the program. So we went from primarily focusing mostly on injection drug users to people also on opiate substitution therapy, also known as medical assisted treatment, also known as methadone and buprenorphine access. So we're now in the majority of those clinics. So we've been able to reach a huge amount of drug users as well as people on those therapies, because what we find is if you are able to get people on methadone and buprenorphine, naloxone, all their mates are still using, and they're more likely to call them than they are to call 911. So we want them to be able to respond to those drug overdoses. We don't want them to replace 911, but we want them to help in conjunction, or if the people aren't calling, this is better than nothing, right? And then what we found is after we expanded the program in 2014, we had 189 reversals during the year. And then this year, we expanded our program even more. We've now passed out 16,000 overdose reversal kits, which include naloxone. And this year, the slide here says 807. We're almost up to 1,000 with the October data set. And so we're seeing a huge amount of uptick in the utilization of naloxone through our community-based organization, which is the largest naloxone distributor in the U.S. South and also the largest overdose prevention trainer in the South. So we're really working on expanding our services in the ways possible. Next slide, please. So, and the next slide will just show you maps of everywhere we've had reversals. The darker the color, the more reversals we've had. And a lot of our reversals have been in Appalachia and Asheville, as well as in the Triad area of Winston, which is Winston-Salem, Greensboro, and High Point. Next slide, please. So I just wanted to give a brief overview of 911 Good Samaritan laws, naloxone laws, and syringe exchange laws. Next slide, please. So 34 states have Good Samaritan laws. 2 of these only have affirmative defense, where it's mostly, it could be considered a mitigating factor in court. These tend to be really bad, not good laws. Because say, for example, if I'm considering calling 911, I'm not going to be thinking about, oh, potentially I can get arrested, charged, and prosecuted, and maybe, you know, in court they'll forget about it, or like say you're cool and you have to serve less time. Like, we really need to give full immunity if we want people to call 911. Georgia has a fantastic Good Samaritan law that provides immunity from arrest, charge, and prosecution, and is the one that should be replicated in the U.S. South over the other laws. The Georgia law is fantastic. We worked with some advocates on it there, and I really applaud Sharon Cooper out of Cobb County in Georgia, who sponsored the legislation and made it one of the best in the country. Next slide, please. You know, and they vary, so some will give immunity from arrest, charge, or prosecution in a variety of different ways, from paraphernalia, some for controlled substances, some for probation and parole, and others will have other protections such as mitigating factors and civil asset forfeiture. Next slide, please. But they're excellent laws in general. Also, with the naloxone laws, they vary. Lots of states have varieties and various subtypes of these laws. And so now it's in the majority of states, including states in the South, which is fantastic. Next slide, please. And what we see is they all have a variety of different angles of where they're providing immunity, from civil and criminal immunities for the dispensers, so people giving it out, for lay administrators, which would be civilians who use it, for the prescribers, and then also, you know, can you, in North Carolina, for example, we have standing orders which says a physician can officially issue a directive saying anybody who works in this community-based organization, as long as they keep a basic medical record, can dispense naloxone in a field, which is what our organization does. And that enables us to go out to the community, to where injection drug users are, to methadone and buprenorphine clinics, and give out naloxone at those sites after brief trainings. Next slide, please. So states also can institute syringe exchange programs, which are excellent programs. 22 states plus District of Columbia authorize these syringe exchanges, allow individuals to bring used syringes back to a community-based organization which may be running the syringe exchange, dispose of it, and get new ones. These programs are proven not to increase drug use, proven not to increase crime, proven to decrease HIV, proven to decrease hepatitis, proven to decrease needle sticks by 66% to law enforcement, proven to improve community health, and also proven to increase the amount of people going to drug treatment, and they're proven to also increase people's access to housing and social services. Basically, syringe exchanges are places where people who've been kicked out of every other service can go and get basic needs met, social services met, and really importantly, use new syringes for every injection, right? Think about it as a place where they're just like one-stop health clinics for injection drug users. And what we know, a lot of people would critique, oh, if you give a syringe to an individual, it's just going to give them an excuse to use drugs. These people are using drugs anyway. What they're going to do is if they don't have a new syringe, they share syringes. If they share syringes, they get abscess. If they get abscesses, they may have to get it treated at a hospital, which is going to cost $4 to $6 grand per treatment. If they don't have new syringes, they're going to get HIV and viral hep C. Hepatitis costs $500,000 to treat. If it requires liver transplant, HIV is going to cost over $600,000 for long-term costs. You can solve this all with 5 cents for a syringe. And there's a lot of private foundation money to provide funding for these initiatives. Next slide, please. So important parts of the effective laws is you've got to think, is it going to provide immunity for controlled substances, alcohol-related crime, drug paraphernalia, and probation and parole? We in North Carolina Harm Reduction Coalition are happy to work with anyone who has questions about how to set up a good law and can talk to you about this. Also, the Network for Public Health Law has excellent resources. Next slide, please. And one of the stakeholders you need to address in the South is the bills have to go through the Republicans. If they aren't primarily through the Republicans, your bills are going to have a lot of difficulty passing. You need law enforcement buy-in, law enforcement and actual partners. You need EMTs and EMS buy-in. You need to find who the players are in your legislature to introduce the bills. Our syringe bills have all come from representatives who are former law enforcement. Our overdose bills have come from members who are mostly from rural jurisdictions that have been particularly hard hit by drug overdose. Also, you may need medical community buy-in. You need user feedback, active injection drug user feedback to make sure these laws actually will benefit them by asking them. And also getting family members who've been impacted by drug overdose to participate, because hearing those personal stories is very important for the legislators, especially stories from their district. Next slide, please. And I'll skip to the next slide. One of the important things is after you pass these laws is you need to let people know. So you need to do a media campaign, you need to do a law enforcement education campaign, because a lot of time law enforcement don't know about the new laws. And if they don't know about the new laws, they won't enforce them correctly. So you need to make sure all the law enforcement know about it so they can implement the laws effectively, and also work with them on setting up law enforcement naloxone programs, and also look at working with them and setting up law enforcement-assisted diversion programs, because those programs decrease HIV, decrease Hep C, decrease drug overdose, get more people into treatment, are utterly fantastic and things that they should be looked at. If anybody has any questions about setting up any of these programs or working on setting up these laws or running advocacy campaigns for the laws or needs technical assistance on implementing or introducing the laws, we will provide you with that. My information is up there, as is my coworkers, and we're happy to work with any state. And we've already worked quite a bit with Georgia, South Carolina, Indiana, and also provided some technical assistance to Tennessee and several of our other states around us in the South. We're happy to work with anybody. If you need anything, please give us a holler, and we're happy to work with you on improving the health and dignity of people who use drugs and the law enforcement who have interactions with them. Thank you for your time.
Great, thank you so much. And our final speaker will be Representative John Tilley from Kentucky, and he's going to talk about the great work that Kentucky is doing.
Well, good afternoon. I see that I'm unmuted. Is that correct? Can you hear me?
You are unmuted, so we can hear you.
Excellent. Thank you. Well, I'll have to say that this presentation might seem familiar to those of you who've been listening, because a lot of the thunder has been appropriately stolen, but that's okay. I'll try to make it unique to our state, and in so doing possibly give you some help in your own. So moving forward, I will tell you right off the bat that Kentucky is unlike, yes, you can move to the next slide. Kentucky is unlike some states in the way this has hit us, but more like most, in that we have an opioid crisis in this country, and it hit the eastern part of our state, Appalachia, as you saw on the map, particularly hard, and it still exists there, even though we're seeing good numbers from a legislative response to the opioid crisis in 2012 and 13 with separate pieces of legislation. I do want to also address the fact that prior to this response to the pill mill crisis and the prescription drug abuse crisis in our country and our state, we had seen an overdose death spike in the 2 quarters previous to the passage of this legislation. So any direct assertion that legislation to crack down on prescription drug abuse did not lead directly to the heroin crisis or the scourge, although it certainly contributes when it becomes more difficult to obtain those pills either from a doctor or from the street, and the expense. I think largely it's market-driven, and I hope my colleagues would agree with that. So you see the spike in overdose deaths there. Next slide, please. You'll see the most detected substances in this slide. You might want to make note of cannabinoids, number 2 there. It's interesting that that would appear. I think some folks think that's no longer the case, so take that for what it's worth. Next slide, please. You'll note some startling numbers here, and I had to repeat this to the media and verify this before they went to print. Some of them, we had a near 1,600% increase from that in that time period, 2000 to 2012, in Kentucky patients, as you see, co-diagnosed with opioid dependence and viral hepatitis. Obviously, from needle sharing, again, an incredible increase. And you heard the cost. Now we do have, I will add something to this. There has been a breakthrough in treatment of hepatitis C, possibly even a cure that is even less expensive, or will be less expensive as a one-time cure than a lifetime of treatment. But that still will be a huge cost, right under probably $100,000, somewhere in that neighborhood, 70 to 100 for the one-time cost of that hopefully cure for that. But that does not decrease this again, alarming increase. Doesn't decrease this concern we should have for it, I don't think. HIV is also a concern. You see the $37 million in cost of the opioid and heroin-related hospitalizations, the increase in that. In 2014, 16,000 Medicaid patients diagnosed with Hep C. That's a 100% increase from 2013. And the $50 million we spent, or 7% of our total budget in this area, on 2 new hepatitis C drugs to just 861 residents. Again, and Kentucky at this point, for whatever reasons, has 7 times the national average in terms of a Hep C rate, a saturation. Next slide, please. One thing that struck legislators in our state, I've not heard mentioned today, was the neonatal abstinence syndrome crisis in our state. You see there in 2012 there were 824 reported cases. That was a 2,843% increase since 2000. And for those of you who've never had the misfortune to hear an infant cry out when it's being weaned off these drugs, you'll never forget that sound, and you don't want to hear it. So there's a great human capital here. But we also learned in the course of our legislation and our efforts to really come up with a comprehensive piece that we could treat dependent and drug-dependent mothers on the front end. We have waiting lists and long lines in Kentucky to get into these very few clinics we have, for $25,000 to $27,000. And oftentimes healthy babies are delivered and mothers come out clean. And what we've now found, though, is when we don't do that, the acute cost right on the front end can spiral past $250,000 very quickly. These children, again, are facing potentially a lifetime of developmental difficulties, although the studies seem to suggest that maybe some of that flattens out. But still, that's a 10-to-1 return on investment if you're following along with your calculator. So to me, that's good public policy. For too long, I think government has been penny wise and a pound foolish when it comes to investment on the front end. You see there, of the $40 million total neonatal abstinence syndrome expenses, Medicaid was billed 35 of that $40 million directly to the taxpayer. Went that cost. Next slide, please. Again, the heroin cost to Medicaid, I just referenced that. You see it right there. Overall cost billed to Medicaid for Kentucky resident opioid-related hospitalizations was $55 million. Again, taxpayer cost that is, again, I think increasing as we speak. Next slide, please. We too, I think Robert spoke very eloquently and right on point with regard to improperly discarded syringes and the need for needle exchange programs, which I'll hit on in just a minute. But we certainly have seen our share in Kentucky along our roadsides. Our transportation cabinet sent us several photographs of just random finds and we certainly looked at that as a problem with regard also to the spread of bloodborne illnesses, and I'll touch on that in a minute. Next slide, please. There's a picture I just referenced there. You can see we found those along the roadside, and certainly we are on watch to keep them out of our schoolyards, and it's been a battle. Next slide, please. All of these numbers and this rise in heroin abuse forced the House and Senate in Kentucky. Democrats control the House. Let's talk politics for a minute, as it was raised by Robert in terms of the South and needing, again, needing Republican input, because every chamber in the South is controlled by Republicans. Every legislative chamber except the Democratic House in Kentucky, of which I'm a member. I'm proud of the bipartisan effort that we've expended with our Republican colleagues in the Senate. And this bill to address the heroin epidemic was truly a bipartisan effort, again, focusing on prevention, treatment, and targeting of offenders. I will say, as it relates to your states, I'm glad to hear that Republican states are moving on the Good Sam provisions, naloxone, and needle exchange, because initially it took a lot of teeth gnashing and a lot of hours behind closed doors and maybe some public pressure for our Senate, some of our Senate members to agree to the Good Sam provisions, the naloxone availability. In some cases, really that was an easier one than the Good Sam and the needle exchange provisions in the bill. And we actually fought over a very controversial piece with regard to penalties, which I'll get to in a minute. But I just thought that was an interesting political dynamic that goes on in Kentucky that may not happen in your states, given that we've probably got, again, nothing but Republican legislatures we're talking with except Kentucky. Next slide, please. We passed a reform bill in 2011. I know that we've worked very closely with Georgia. There are other states in the South. South Carolina has been a big proponent of justice reinvestment. I've worked with them as well. The savings we've encountered and seen in those areas, we tried to put to the things you see listed: more drug treatment in county jails and our community mental health centers, more grants for drug-dependent mothers and their children, the babies, on the NAS provisions, funding for traditional drug abuse prevention, medically assisted treatment in our state prisons. We've seen great success with the use of Vivitrol. I think we need to use medically assisted treatment, or MAT as it's known, and we need to continue to expand that, especially as a response to the opioid crisis and opioid dependency, as evidence-based practice suggests it's the best way to get people on the road to recovery. Our Department of Public Advocacy has an award-winning program, a social worker program. We, again, funded that at a higher rate, and our prosecutors asked for money for a rocket docket, and that seems to be moving in the right direction as well. We included an additional $10 million emergency appropriation from some rainy day money, essentially, that went into this bill to fund some additional programs, the one you see listed as well. And this was a non-budget year, so you see when we crack open the budget in a non-budget year, you know that there's a certain importance and a critical nature applied to it. Next slide, please. Naloxone has been talked a lot about today. Maybe the difference in Kentucky, I don't know of any other state outside New Mexico that does this. We pushed for Naloxone Access at pharmacies. Our doctors came in, our pharmacists said they would do it. They've been quick to jump to the aid, in this case, our aid as a state, to dispense naloxone. I agree with everything that was said about naloxone. I don't think there are any harmful side effects. What we did was, again, give it to pharmacists. They can give it without a prescription as long as they have a protocol for the local physician. I spoke to a group of pharmacists at a leadership banquet last night, and the number of pharmacists who have registered in our state is astounding. And they have really grasped this and are waiting to do more. They're also their registration of our PDMP, which is Casper, which I appreciate the kind words. I do believe it to be the gold standard in the country. It is required of all physicians to use Casper when prescribing an opiate now. And I will tell you that not only have they registered in high numbers, obviously as it's a requirement, excuse me, but our pharmacists have seen a 324% increase in their registration and are using PDMPs at a high rate, just voluntarily to help in this scourge. And they also are willing to come to the table, and I hope to introduce some legislative initiatives in the future to bring pharmacists along as we continue to enhance their provider status. I think that's critical moving forward. You see in there, we also allow schools to administer naloxone with school board approval and to store it on site. Next slide, please. There's the good SAM protection we talked about. Ours, it does have some unique characteristics. I don't believe it to be as all-encompassing as the Georgia piece that was discussed. I hope we can tweak it in the future, but it is a good piece, and it does provide that defense, not an affirmative defense, but it does provide that immunity. We thought it had to do that. We did grapple with our colleagues in the Senate over that. A couple of voices were against the good SAM protection. They're actually asking us to revise it now to make it more difficult to use the good SAM protection. So any help we can get in Kentucky to anything you might think to help us advocate for a more expansive and a more usable good SAM protection, I think it would help us. Next slide, please. Officer safety and syringe exchange, you see there, that's been noted, the danger to law enforcement, the danger of sticks, and we have immunity for the declared paraphernalia as well there, so that's important. Also, you see now we did empower local health departments to request a needle exchange program. It has to go through the city council or the county commission or magistrates, as we have in Kentucky, depending on where the syringe program will be located. We've seen programs crop up since the bill became effective late spring. We saw them crop up in Louisville, and I'll show those numbers in a minute, and Lexington, our two largest cities. And sadly, we don't have any programs in northern Kentucky yet where the heroin scourge is really hit the hardest, and they're grappling with the policy behind those. And again, these programs, again, Robert stole all my thunder. I could not be a bigger proponent of these programs and what they do. It's counterintuitive. They simply do not increase drug use. In fact, one thing Robert may not have said was they increase the likelihood by 5 times that somebody who appears there will seek treatment. Again, they're 5 times more likely to seek treatment. Next slide, please. I know I'm running short on time. I'll be quick here. Here's those convicted, the controversial, I think, penalties. Those convicted of trafficking more than 2 grams must serve 50% of their sentence before probation or parole eligibility. Kentucky already has some of the toughest drug laws in the country, and certainly in our region, I think, with enhancements. And there were some who believed that we needed to focus on prevention and treatment. I do believe that we achieved a balance here. That was, again, a controversy in our state. We achieved a balance between those things, and this is obviously on the interdiction side. And you see those before you. They're stackable offenses. 2 days into the bill, I think, we had caught someone who was importing heroin, and they're being prosecuted at that level now with a stackable offense. We also have aggravated trafficking measures in our bill. You see there for those trafficking 100 or more grams of heroin, 10 to 20-year sentence with 50% time served requirement. Next slide, please. I think we were ahead of the curve with fentanyl and acetylfentanyl, thanks to our Drug Control Office alerting us to what these synthetic opioids do and how powerful and dangerous they are. And you see they've been blamed for a sudden spike in overdose deaths. Strengthened coverage of fentanyl, and our law is what we were trying to achieve, and we did that. We designated acetylfentanyl as a Schedule I controlled substance, and again, you'll see harsher penalties for the use of those synthetic opioids. Next slide, please. And there's, again, our neonatal abstinence provisions. We give pregnant women priority to state-funded drug treatment programs. We bar them from discriminating against these dependent mothers if appropriate care is available, and we also give them safe harbor under certain conditions from the termination of parental rights. I believe that to be a critical piece as well. We're seeing great success in a number of our facilities that offer these programs to drug-dependent mothers, a number of healthy babies, and some real success stories. And again, the human capital here is the suffering is incalculable, and I think that's what we focused on from our side of things in the House, and I know the Senate came along with us, had a lot of bipartisanship on this particular effort. Next slide, please. There's more of the safe harbor stuff. I won't belabor that. I know as we're out of time. I'll field any questions with regard to specifics there. Next slide. And there's the early numbers. I'm on the last two slides here, so I'm wrapping up. The Louisville Syringe Exchange Program, you've seen the numbers, 822, almost 25,000 used syringes collected. I will say this, and I'll finish up. Louisville is 35 miles from Clark County, Indiana, and the nation's aware of Clark County, Indiana, when their public health director made the notable quote by saying that their HIV levels had reached those of sub-Saharan Africa. And that can happen anywhere in the country with the heroin epidemic and needle sharing. And so I think that helped us propel a number of reluctant members into agreeing that we need to give communities the right to begin these programs. And so I applaud the work of Robert when I'm talking about how important they are and his organization there. And I'd love to talk to you afterward, Robert, on that as well. Last slide, I believe, is coming up, which just shows Lexington's very early entry into this. I'll say the distinction between Louisville's program is that it's a need-based model where there doesn't have to be a one-to-one exchange, and there are a lot of reasons, policy reasons for that. That's evidence-based policy. Lexington is a 1+ model, for those of you who know what that means. So they're requiring some type of exchange, but they have what's called a 1+ model, and I'll field questions on that if anything specific. I believe at this point I'm probably out of time, and again, I'm happy to field any questions. Thank you.
Great. Thank you so much. I think we had 3 great presentations. That's given us a lot to think about. So we are kind of getting to the end of our hour, but we do have a couple questions. So I'll go ahead and offer these up. But if there are any questions that you have that we aren't able to get to, please feel free to send them to me, and I will make sure to get them to the appropriate presenter afterwards. So our first question is for Jack. As states are working to reform their criminal justice systems, as Representative Tilley alluded to, are the people you're encountering repeat offenders? Do states need to have tougher heroin penalties? Is that something that would be helpful, or maybe not as effective as we think?
Well, from where the high-intensity drug trafficking area program works, there are times I could say I'm not so much in the drug business as I am in the gangster business. And most of our attention is paid to those transnational criminal organizations. As we work down, and I was very interested to see what Representative Tilley had presented that they're doing in Kentucky. As you begin to kind of work down the chain of distribution, there are levels of mid-level professional drug traffickers. You come to a point where your trafficker is an addict who is dealing in drugs probably at the behest of a professional trafficker who does not use drugs solely to support their habit. And at that point, I think we're going to all have to come to kind of a clear differentiation of who's a diseased victim where we need to take an appropriate treatment response, and that response might be drug court rather than more severe penalties. In other words, if the person isn't seeking treatment by themselves, faced with their responsibilities to answer for their acts in the criminal justice system, we can have some effect in putting them into a treatment program. And that's proven fairly effective around the country. On the other side of it, we do excellent work, much better work with our partners in Mexico over the last decade than previously, to both bring the major suppliers to justice, and they do face significant penalties. These are not the nonviolent drug traffickers that we discuss. So just simply ratcheting up the penalties, I don't know that that's as much help as taking the kind of full spectrum response we've had a great opportunity to talk about this afternoon.
All right. Our next question is for Robert. So some good SAM laws, obviously, like you mentioned, differ a little bit as to what they require. Have you all found that the ones that require the caller to maybe give their name or provide a little bit more connection to themselves have been have they been equally as effective as maybe those that allow them to remain anonymous?
So the point of the Good Sam laws is to encourage people to call 911. The more complicated and more complicated they become, the less likely somebody is to call. So if our goal is to reduce overdose mortality and increase buy-in into getting EMS to respond to drug overdoses and law enforcement to respond to drug overdoses, we should be reducing barriers to do so. So take, for example, in North Carolina, we have immunity from prosecution, but we don't have immunity from arrest and charge and prosecution, similar to what Georgia has. So Georgia kind of has the gold standard in the South right now. What happens in North Carolina is individuals may get arrested and charged. We'll do trainings about these laws in jail and in prison, and people are like, I'm hidden here for this. Like, I didn't know I couldn't be prosecuted. And what message that is sent to the community is Good Samaritan laws cannot be trusted, right? So if we have these like partial immunity laws, they just don't work that well compared to Georgia's bill. And there's like great quotes from Chief Ken Ball out of Holly Springs, Georgia, where he's like, we haven't found any dumb bodies since we passed these laws. Because what happened is people are now not afraid to call 911 if there's a drug overdose, which is utterly fantastic. Law enforcement have bought into it there, and high frequency, it's a great law. Where ours, people are like, I may not be prosecuted, but I'm going to spend some time in jail. That makes them think about it. And we don't want people to think about it. We want them to call, right? That should be the priority. In North Carolina, we also have, we just passed it this year, where somebody has to give their name on the phone. But when we polled active users, they said it wasn't a big deal to them, because if they said they were calling, the person has their ID already, because almost everybody has cell phones. So to them, it was like, I'm calling. I don't think it's a big deal. But some people won't call if they have to give their name, and that just is what it is.
Thank you. All right, and one more question for Representative Tilley. Can you just briefly discuss why Kentucky, decided to require certification and training for the pharmacist? Because that is something that varies from state. So if that was just something you could touch on for a second.
Yeah, for the dispensation, distribution of naloxone, I assume we do require that training. I think it's, again, it's more or less, I think, to engage the pharmacist, first of all, that has not been a barrier. I don't think, they don't need much training. Someone mentioned, I think it was Robert, mentioned the nasal tech, and I'm proud to say that the patent, I think, for that, the gentleman was a professor at the University of Kentucky, and so that's coming down the pike, and that'll be even easier to use. So our concern was just that pharmacists are understanding of what they're to do, which is inform whoever picks up the naloxone, the Narcan in this case, the brand name, picks it up and understands how to use it, understands really it's not so much the negative side effect, but they have to be used again, that one dosage, one injection or one administration of the medication may not be enough. You have to keep your eye on the overdose victim and maybe give them a dosage. And that's really one of the main things we talked about, was just that limited amount of training, not just to the pharmacist, but to those using the naloxone, is critical.
Great. Thank you so much. All right, so I'm afraid that's all the time we have, but I want to thank all of our presenters. We're very appreciative of the time that you've taken and your contributions today. Again, if there are any questions that you have for our presenters that we weren't able to get to, please send them to me and I will forward them on. I also would like to thank my CSG colleague, Carrie Abner, for her help and the technical assistance for today's webinar. And if there's anything we can do to assist you in your work, please don't hesitate to contact the SLC, and we hope you enjoy the rest of your afternoon. Thank you so much.